Hi, good afternoon. Okay.
Yes.
Okay, let's start. So basically, this is a 24-year-old primary gravida who is teacher by profession who presented to the ER 34 weeks of gestation with severe abdominal pain and generalized swelling all over the body. There was no significant history and pregnancy so far was uncomplicated. Her antenatal record has shown blood pressure of 140 by 90 and pitting edema in the ankles. On arrival in ER, her blood pressure was 146 by 110. 164 by 110. Initial evaluation was done and blood samples were sent. These were her vitals. Okay. So my question here is, what is your preliminary diagnosis? Anybody? So we'll have this class session like a discussion. So I am welcoming all of you to actually answer also, so that we can have like a discussion instead of like a one-on-one session. So what is the answer here?
Preeclampsia.
Severe
Yeah,
preeclampsia.
good. Preeclampsia. What else? What else is possible?
Pregnancy-induced hypertension.
Yes, very good. Pregnancy-induced hypertension. Very good. What else?
Pregnancy-associated hypertension.
Yes, pregnancy-associated hypertension, pregnancy-induced hypertension, gestational
Peri-
hypertension,
Pancreatitis.
and preeclampsia.
Pheochromocytoma.
Sorry, come again.
Secondary.
Pheochromocytoma.
Okay. So secondary causes of hypertension you're thinking of. Okay. So what will you do at this point? So these are the vitals of the patient. Where will you keep the patient?
On a
ICU.
monitored bed.
Okay, good. You will keep the patient in ICU. Okay, good. So, and what all investigations will you like to send in this patient?
Renal light, electrolytes,
Okay.
and urine analysis for albumin.
Yeah.
Blood and
Abdominal ultrasound. For the baby, we will make
Okay.
CBT, that's one. And
What other investigations would you like to send at this point? Anything else?
Including blood gas and coagulogram.
Yes, good. So, what is the diagnostic criteria for preeclampsia? Anyone?
Hypertension.
significant
Blood pressure
proteinuria
more
of
than
more.
Yes. You have to tell about proteinuria. Good. Then,
Organ dysfunction with epigastric pain.
no, epigastric pain is not the diagnostic criteria for preeclampsia. So, proteinuria is correct. How much proteinuria?
3 grams per day, more than 3 grams per day.
Correct. More than 3 grams per day. Then,
so thrombocytopenia if it's
very good. Very good. Platelet count less than 1 lakh is
less than
also.
1 lakh.
Yes, very good. What else?
Elevated liver enzymes if
Very good. Elevated liver enzymes, that is transaminitis, at least twice the
twice the upper
limit
limit of
normal.
yes.
Very
Yeah.
good. So we told proteinuria, we told elevated serum creatinine, we told platelet count and elevated liver enzymes. What else?
Hemolysis will be there, but it is HELP syndrome.
Correct. Hemolysis is not included in a part of preeclampsia.
Preeclampsia, right?
Yes, HELP syndrome you can always tell as a differential diagnosis, but hemolysis is not included in that. So other things are new
Right
onset.
hypochondriac.
Yes.
Right hypochondriac pain.
Yeah, correct. So
Blurring of vision.
Yeah, blurring of vision, like visual symptoms, flashing lights, and sparks like that is included. Pulmonary edema and new onset headache. So So diagnostic criteria also is very important that any of this is present along with increase in your blood pressure. That is systolic more than 140 with diastolic more than 90 at least 2 occasions at 4 hours apart after 20 weeks of gestation with in a previously normotensive
Normotensive.
patient. Yes, with one of the following which you said, that is proteinuria, platelet count, serum creatinine, elevated transaminitis, some vision problems, pulmonary edema, and new onset and persistent headache. So basically, any of this is actually present with hypertension, that is 140 by 90 Q per your blood pressure at 2 occasions, which are at least 4 hours apart. After 20 weeks of gestation is actually the diagnostic criteria for preeclampsia. Okay, clear? Clear? Everybody?
Yes, yeah. Thank
Yes.
you.
Another thing is actually in patients with preeclampsia with severe features, what are the severe features of preeclampsia? Or what is severe preeclampsia? If you
So
don't
when
know,
blood pressure,
write it down. These questions can be frequently asked in your pregnancy obstetric emergencies. So what is severe preeclampsia? Anybody?
blood
Blood
pressure
pressure
of more
more
than 160 by 110,
Yes, very good.
along
Again,
with
more than 160 by 110.
along with worsening this lab parameters as well as clinical features like platelets dropping, transaminitis worsening,
Yes.
headache or blurred vision.
Good. So again, you have to tell systolic blood pressure more than 160, diastolic more than 110 on 2 occasions which are 4 hours apart, while the patient is on bed rest. However, antihypertensive therapy generally should be initiated upon severe hypertension, in which the criteria for severe blood pressure can be satisfied even without that 4 hours of waiting period. Apart from that, you'll have visual disturbances, severe incapacitating headache, elevated liver enzymes more than 2 times the normal, severe epigastric pain, thrombocytopenia with a platelet count less than 1 lakh, and kidney impairment or doubling of serum creatinine in absence of any other kidney disease. This is the features of severe preeclampsia. Now we'll go to the next vignette. What happens to your patient after this is that you secured IV access, you started labetalol, and in front of you, she started throwing seizures. Her blood pressure was 190 by 120, and investigations had arrived. And these were your investigations. I'll give you a minute to actually see all the investigations. So, what is your diagnosis here?
Eclampsia.
Eclampsia.
Correct. And how do you manage this patient?
Anti-epileptics, magnesium sulfate, control of blood pressure, and
Very
early
good.
termination of pregnancy.
Very good. And what is your
Air.
dose of magnesium sulfate?
There are 2 regimens, Juspans.
Correct.
And Pritchard.
Yes, good. What is your
Uh,
Pritchard regimen?
It's 4 to 6 gram IV. We give it over 20 minutes.
Correct.
Then we start infusion with
Correct.
2 gram per hour.
Correct.
For at least we need to continue it for 24 hours or
48 hours.
post delivery 24 hours.
Okay. So what if there is breakthrough seizures after giving your loading dose? Patient is already on maintenance dose. What will you do?
We will give
gram
another
more.
Termination
loading
of
dose.
pregnancy.
We need to give benzodiazepines also here, then Lopez or maybe Levipil. Once the
More magnesium.
fetal delivery is done.
2 gram magnesium again.
We can repeat the magnesium dose, yeah.
Yes, correct. You can give again 2 gram of magnesium. So that is basically eclamptic seizure. So up to date, if you see, there is actually a good algorithm that first you give 6 grams and then you start the maintenance dose. If another seizure occurs, you give another 2 grams of magnesium over 5 minutes. Then again, you resume the maintenance dose. And if the third seizure is occurring, what will you do?
Termination
So,
of pregnancy.
yeah, that is there. But what in terms of anti-epileptic? Will you give another magnesium or will you give something else?
Benzodiazepines and other anti-epileptics.
So
We
what
can-
the guideline says, you can give phosphonatoin or phenytoin. Okay, at the same time, you don't have to do emergency termination of pregnancy. You have to do cardiac monitoring and of the fetus and the vital signs of the fetus. But the guidelines doesn't say that immediately you have to take the patient for C-section. You can give another anti-epileptic by discontinuing magnesium sulfate like phenytoin and phosphonatoin. And after that, you can just observe the patient and do the fetal monitoring and see. Okay. So what are the signs of magnesium toxicity you guys know of? How do you monitor the magnesium toxicity levels in a patient?
Decreased
Urine output,
patellar.
deep tendon reflexes and respiratory rate, and urine output and magnesium level 6 hourly.
So what is the first manifestation of symptomatic hypermagnesemia? My question is very simple. What do you monitor?
Bradypnea.
Loss of deep tendon reflexes.
Yes, very good. So basically, the
Knee
thing where the management regimen goes like this: you give the loading dose before starting the maintenance dose. You check for DTR. If the DTR is present, then only you start the maintenance dose. Understood?
Yes.
Yes. Yeah. So you have, and the second thing what you have to see is what? Apart from DTR, deep tendon reflexes.
Urine output.
Hourly urine output.
Yes. Another one. Three things you have to
Respiratory.
Respiratory rate.
Very good. So respiratory rate more than 12, urine output should be good, and deep tendon reflexes should be present. But the first sign is always deep tendon reflexes being lost. So if it is present, then only you start your maintenance dose. What is the therapeutic magnesium level we want? Therapeutic range.
2.5 to 3.5.
What is
4
the
to
unit of that?
7. 4 to 7.
Milliequivalents meds 4 to 8 milliequivalents per liter. Or
More than 7 is toxic.
So 4 to 7 is actually milligram per deciliter. Please go and
Yeah,
read through it.
milligram.
And what milliequivalent per liter, you're saying the range is 1.9 to 3.5 or 1.8 to 3.5. So please go and be very clear with the range of the therapeutic because it has a very narrow therapeutic range. So all the drugs which have narrow therapeutic range, you need to keep that in mind. Right. Okay. What other drugs can actually concurrent use of what other drugs along with magnesium sulfate can precipitate toxicity?
Phenytoin itself.
Okay. That's why we have to stop it actually before starting. That is correct in a way. What else?
Can precipitate toxicity in this case?
No, not in this case, usually. So you cannot give them with calcium channel blockers because they precipitate hypotension. And another thing also to remember is that apart from precipitating hypotension, there are other things also which you need to think of. Like it's a myasthenia patient, you'll not give magnesium. So the contraindications of magnesium we need to be aware of. Okay. So this is your patient throwing eclamptic seizures. You told about how you're going to manage this patient and what are the drug of choice. You contact the obstetrician also. You get an ultrasound abdomen done. You see mild pleural effusion. You see minimal ascites, increased echogenicity in both the kidneys, 35 weeks, and normal liquor. The obstetrician decides to emergency C-section. The patient is transferred to OT, and one baby is female baby is delivered. The patient starts bleeding in OT, which could not be controlled despite of oxytocin and misoprostol. Hysterectomy was done, and patient was shifted back on the ventilator with NORAD support. In ICU, this is the vitals. So as we all know, it looks actually kind of bad. Tachycardia with hypotension on NORAD support. What will you like to do right now?
Blood products, massive transfusion protocol activation of this.
Correct. Very good. Yes. So you have to see how much is what any point of care test you want to do right now to see exactly any information you want from that, what blood products to give or something.
TEG or ROTEM?
TEG is available.
Yeah, whatever you're comfortable with, you can answer TEG or ROTEM. And exactly, basically, you can do TEG guided resuscitation as well. Apart from that, do you want to send any other labs? So what labs would you like to send here?
CBC to see for the hemoglobin levels.
Correct.
Creatinine levels.
Okay. But apart from that, in hemogram, anything else you want to see apart from CBC?
Platelet count.
Platelet, yes. That is in CBC.
Liver enzymes, abdominal ultrasound.
No, in hemogram, anything else?
Peripheral smear and serum calcium levels.
Yeah,
Peripheral smears for cystocyte cells.
Correct. But when the patient is losing so much of blood, one more thing which we like to see is fibrinogen levels.
Yeah.
If you have to give cryoprecipitate or not. So you always say fibrinogen levels, PT, INR, APTT, and hemoglobin platelets overall. So basically the entire DIC
DIC protocol.
protocol thing you can actually tell, because this patient is given multiple transfusions, still continues to bleed, hypotensive, tachycardic. So you can mention about
If
that.
we have mentioned tech, then also it's better to mention all the
Yeah.
routine lab parameters also. I mean,
Probably.
this fibrinogen and
Yes.
INR repetitive.
Yes. Yes. Because tech might not be available everywhere, but at the same time, you want to actually get tech is overall a qualitative assessment, but for quantitative assessment, you need to send labs.
Yes.
Yeah. So tech is more like, it'll just tell you a figure of, if platelets are deficient, if fibrinogen is deficient, or if hyperfibrinolysis is happening. But to actually get an evidence of that, you need to send labs, right? Okay. So this is where we are. Yeah, tell me. You're saying something? Okay, we'll move ahead. So 24 hours later, the patient continues to ooze from surgical site. She remains drowsy, moves minimally to pain, and her heart rate is 100. Blood pressure is 136 by 76. She's on NORAD and vasopressor support. Urine output is actually only 20 ml in last 4 hours. And hemoglobin is 8.4. TLC is 14,000. Platelet count is 70,000. Blood urea nitrogen creatinine is 56 and 2.5. So can you list out the issues with the patient right now? What are the issues going on?
Dropping hemoglobin and platelet count, worsening AKI,
Correct.
increasing LDH and liver enzymes, and coagulopathy. Like maybe she's going into DIC now. Fibrinogen is 65, INR is high, and low
So it's
platelet.
very
Uh,
low. Correct.
AKI, decreased urine output, potassium
increasing
5.6.
So some sort of, sir, high LDH inflammation is going on,
So it's
hyperinflammatory shock.
like HELP syndrome also, or it can be a DIC like picture.
Yeah. Okay. What are the causes? You already said it could be HELP syndrome, it could be DIC, it could be postpartum hemorrhage, and all that.
Massive transfusion, dilutional coagulopathy, consumptive
Yeah.
coagulopathy.
Coagulopathy also, massive transfusion, possibly causing all these complications. So anything else you would like to do at this point of time?
We need to
Advanced,
have like invasive lines and for monitoring ultrasound
Correct.
guided.
Correct. Yeah.
Yeah,
Central line heart line
T, we
should
can
definitely be
start.
there.
we can start advanced hemodynamic monitoring to guide our fluid resuscitation further for this
Yes, very
patient.
good. Good point. Good point. We should start hemodynamic monitoring to actually know exactly how much fluid to give, how much vasopressors to titrate. That's a good point. Then, do you want to seek a nephrology consultation to see if anything
We
else
can,
can be done?
if patient is having worsening acidosis also, we will need to consider renal replacement therapy in this case also.
Yes, one more thing that you should get an ABG done at this point of time to see exactly, because urine output is only 20 ml in the last 4 hours. So whenever some kind of case like this comes through, this is for an exam, that get an ABG done, because you want to know how much is the metabolic acidosis, how much is the
Lactates
lactate.
must be high.
Yes. So for ABG, you need to get done immediately to see exactly. And you can always ask also that, I would like to see the ABG of the patient to know if the patient is having severe metabolic acidosis or those sort of things. Okay. So we'll move next. Apart from that, again, you can involve the nephrologist, you can involve the hepatologist also. But they won't add much apart from supportive treatment in this patient. So patient condition is extremely critical, and husband and parents understand that likely she might not survive. And they have actually decided to opt for organ donation at an earlier thing. And the social worker has also informed the organ donation committee, and the process has already started. So we will talk a little bit about organ donation here. So what are the prerequisites for considering a patient for organ donation?
Like
Hemodynamic stability, normal
Okay.
electrolytes.
Yeah.
Patient
no
should be
hypothermia. Temperature should be more than 36.
Correct. Correct.
Uh,
Okay.
no
we
any
should
metabolic.
we
This
should
is for brain death documentation. Tell patient GCS more than 3.
Okay. So apart from all this, so you decided to go for apnea test. Can you tell me the prerequisites for going for apnea test also?
we should
Temperature.
make sure that there is no brainstem reflexes present. We should make sure.
Then, apart from brainstem reflexes, what else? What are the
Uh,
prerequisites?
Of sedation since 5 half times of the sedative.
Patient's vitals should be should be needing minimal dose of supports.
Correct.
Systolic blood pressure should be more than 90.
Patient should be
Temperature should
hemodynamically stable
stable.
Yes.
Normal
with
sodium level and better.
normal serum sodium levels and electrolytes.
Then EVG with a PO2 of more than 200, and that is for that when we do pre-oxygenation.
Correct.
The baseline PaCO2 should be 40-45. Otherwise,
So
we
basically,
can
we
just
have to tell about everything. So we have to tell about electrolytes. We have to tell about
any drugs.
Sugar levels.
vitals,
The sugar
everything.
level should be normal. No hypoglycemia should be there.
Correct. Correct. Yeah.
Metabolic
Temperature
energy.
should be normal. No hypothermia.
Hmm. Correct. Okay, good. So this brings to our CCS 4 minutes. So you got a brief idea of about an obstetric case actually, which went into pre-eclampsia, then OT happened and post-op complications, and then patient did not make it, so had to go for brainstem death. So the questions will be centered around that. So you can read all these important cases of obstetric hemorrhage, pre-eclampsia, eclampsia, gestational hypertension, help, basic things to how to manage them in ICU. We'll go to CBS. So CBS, a 70-year-old man is presenting with rapidly onset of ascending paralysis followed by gastroenteritis. He is referred to critical care for increase in dyspnea and tachypnea. His clinical examination is confirming that there is bilateral lower limb and upper limb weakness with diminished reflexes, and this is your CSF sample. So what data is missing in this case?
Proteins.
Yeah, very good. So what is your diagnosis?
AIDP's GVS.
Yes.
Yeah, very good. So what is your indication for ICU admission?
Sorry.
What is your indication for ICU admission?
If patient is
I cannot hear
retaining
doctor.
CO2, the breathing pattern is not good, or respiratory acidosis, bulbar weakness, or
Single breath count of less than 20.
Yeah. So any thing which can actually lead to the patient getting intubated in the next few hours, or rapidly progressive weakness is there. So you should admit such patients in critical care only. Next question. A 55-year-old gentleman is presenting with septic shock and mechanical ventilation. So after initial improvement, he again started having fever, hypotension, abdominal pain. And when you did a CT contrast, this was the case. What is the diagnosis here?
Maybe calculus or calculus
calculus cholangitis.
Very
Right.
good. Yeah. So what is the treatment option here?
ERCP can be done.
Yeah.
Percutaneous nephrostomy.
Percutaneous nephrostomy.
And not
Sorry,
cholecystomy.
Yeah.
Yeah.
So what is the diagnosis again? Sorry.
So it's acalculous cholecystitis.
Okay.
So immediate treatment option is that we can go for ERCP in a patient, septic patient with pancreatitis in this case. 61-year-old patient is presenting in ICU with septic shock, CT
So
abdomen.
there's also pancreatitis. Oh no.
Sorry.
Is there pancreatitis also or not pancreatitis also? Is there
So this
pancreatitis?
is calculus cholecystitis, but if the patient is having abdominal distension and patient sepsis is not getting better, then you have to go for this thing, ERCP to actually find out what is going on.
And the answer to last question would be if the patient is having calculus cholecystitis, then ERCP is indicated in patients with pancreatitis.
Yes.
Ascending cholangitis, if it is there, then that is the indication.
If there is ascending cholangitis, then definitely you have to urgently undergo for ERCP because that is a source control. You have to get it done in patient with pancreatitis.
Gallstones also, if gallstones causing pancreatitis, then also you should consider ERCP.
ERCP, correct.
Yeah, but if there is no ascending cholangitis, then you should not do it immediately. If
You have to wait, you can wait for that, yeah. 61-year-old patient is present in ICU.
Ma'am, the case of acalcular cholecystitis, only antibiotic and nephrostomy. Why ERCP? Acalcular cholecystitis, so we have to go to antibiotics and cholecystostomy. Why ERCP? يعني CT is not proving pancreatitis.
Yeah, this CT doesn't look like pancreatitis, no.
So cholecystostomy and antibiotics.
Yeah, that should be it. No, we are
Yeah.
talking about the next question. That if there is, what is the indication for urgent ERCP in a septic patient with pancreatitis?
Oh, yes. Okay.
For the first question, the answer is your acalculous cholecystitis. And you can go for a cholecystostomy for that. We are talking about if there is a need for urgent ERCP in a septic patient with pancreatitis.
Because there is issue with the sound. I cannot.
Ma'am, sound is far.
Is it okay? But I'm actually sitting right here, and my laptop is also having full sound. Is it better now?
Oh, yes. When you are near to the laptop, it's okay.
Okay, got it. Okay. Sorry. Okay, we'll move to the third one. This is clear.
Clear. Oh, thank you.
61-year-old patient is presenting in ICU with septic shock. This is the CT after initial fluid resuscitation. What is the diagnosis?
Emphysematous pyelonephritis.
Left-sided emphysematous pyelonephritis.
Very good. So what are the components of 1 hour bundle?
Early administration of antibiotic, lactates, fluid
First, you
boluses,
check
and
lactates. Send check lactates.
blood
T-measure
culture.
if initial lactates more than 2. Send blood culture. Start broad spectrum antibiotics.
Okay.
Then
Fluid
IV
bolus,
of
30 ml per kg.
30 ml per kg over 3 hours, but again assessing hemodynamic dynamic indices.
Okay. What is the indication for steroids in this patient?
Refractory shock,
Yes.
not improving with the vasopressors.
Vasopressors of 0.35 to 0.5 mics per kg.
Correct.
Can we say diagnosis again? Kindly.
Emphysematous pyelonephritis.
Fever, myalgia, hypotension, and after that you see this rash.
Purpura
What is-
fulminans.
Yeah.
Very good.
It's
What
early
is the likely
DIC.
cause of purpura fulminans?
Sepsis, septic shock, early
Autoimmune
DIC.
drugs can be idiopathic.
Yes, it can be drug induced also.
And how do you treat it?
Steroids.
Plasmapheresis is.
What is this again? Mainly?
We need to give anticoagulants if patient is it's a thrombotic variety of DIC. So we need to give anticoagulation also.
Can I have a question?
And role of IVIG is also we can try.
Yes, tell me. What is the question?
Sorry for when the question asked it so many sometime people ask it in the same time, so I don't hear what is the answer.
Oh, sorry. Okay.
So
what
kindly,
is
if
the
we can
question?
regulate this thing.
So this is basically purpura fulminans, and the question is actually what causes purpura fulminans. So what is the how do you evaluate, and after that how do you treat purpura fulminans? So that is what they were answering basically. So it could be secondary to a lot of things like like they said, meningococcal infection is possible, or any anticoagulant deficiency like protein C, protein S deficiency can actually cause this. And actually, for your benefit, I'll repeat like the answers again. And what is the management of purpura fulminans is basically the question. So they were saying that depending on the differential diagnosis, first is obviously to treat the cause, and after that you might have to give anticoagulation in patients in which purpura fulminans is basically secondary to thrombotic state. And apart from that, sometimes if the patient is having low platelet count, like less than 10,000, you have to give platelet. But basically, it is to treat the cause. The primary thing is treating the cause of purpura fulminans. Okay, we'll move to the next question.
Sorry for my many requests, but your voice, unfortunately, sometime clear, sometime not clear.
Okay, okay. I'll try to be closer.
Ma'am, if there is earpiece or if you can use headphone or something.
I don't have anything right now. I'll try to be closer to the laptop. Okay, yeah.
Okay.
So next question is, 40-year-old male is presenting to the ICU with blisters in the right foot, which got infected, and patient is having high-grade fever, hypotension, and low urine output. This is the ABG. What is this ABG? And what are the causes? Name at least two.
High anion gap
High
metabolic
anion
acidosis.
metabolic acidosis
Yeah, everybody is clear. This is high anion gap metabolic acidosis.
with hyperkalemia.
High anion gap metabolic acidosis with hyperkalemia. What are the causes of high anion gap metabolic acidosis?
In this case, if there is a history of diabetes, then DK or even the septic shock, uremia, renal dysfunction, certain drugs, toxic injections,
Rhabdomyolysis.
or rhabdomyolysis.
Yes, good. So please remember the mnemonic of high anion gap metabolic acidosis. So DKA, starvation ketoacidosis, poisoning, renal failure, all these are the causes of high anion gap metabolic acidosis. A 70-year-old patient is admitted with community-acquired pneumonia. He was started on day 7 of antibiotic therapy, piptaz and clindamycin. Currently, patient is having severe abdominal pain and explosive diarrhea. And this is what the X-ray looks like. What is this?
Toxic megacolon secondary to clindamycin induced
Pseudomembrane
infection.
Yes. So it is toxic megacolon secondary to antibiotics like probably clindamycin. How do you evaluate this patient? You have to send stool for
Stool
C. diff.
CD.
And what is the first
Toxin A,
line?
toxin.
oral vancomycin or fidaxomicin.
Yes, oral vancomycin is there, or if it is severe, we will give oral vancomycin plus IV metronidazole and alternative option is fidaxomicin.
Atovaquone.
Yeah. 72-year-old male is presenting with diabetic neuropathy, CKD with emergency department with hypotension, tachycardia. He is mildly tachypneic. There is bilateral lower limb swelling also. Sensation of the right leg is not there. Patient has not had to pass urine, which is black, dark brown with foul smelling. And there's crepitus to deep palpation also. In ED, basically, you did the ultrasound. You saw that you could not see much. This is the picture actually. So 120 heart rate, BP of 86/54, patient is tachypneic, saturation is low. What is your diagnosis here?
Necrotizing
fasciitis.
Understood, everybody? It's necrotizing fasciitis. Okay, so that's your professional diagnosis. What image abnormality you see? There is hyperechoic shadows presenting in the ultrasound wave. And what antibiotics will you give?
gram positive and gram negative sepsis.
Clindamycin. If shock is severe, then we can give vancomycin. Otherwise, the clindamycin, piptaz.
Yeah, meropenem vancomycin plus clindamycin is a good combination. So you have to.
Patient is in shock, so we will give beta lactams like.
Yes, good.
Meropenem
Meropenem should be okay. Yeah.
Ma'am, I cannot appreciate what is in the CT, please.
What is the what? Sorry.
Ultrasound, what is showing? I cannot appreciate this one.
Yeah, because it is so necrotizing fasciitis is that only. So there is hyperechoic shadows. That's all. Not much is appreciable because there's so much of tissue edema.
Oh, okay.
Yeah. But your patient is presenting. So if you see the history, you can see that he has lost sensation over the right leg. He has not passed urine. When he's passing urine, also it is extremely dark. His legs look shiny. His crepitus is there. So all these are indicating that it is necrotizing fasciitis. And if the patient is coming, he is coming in shock with a low blood pressure. Correct?
Okay, thank you.
Yeah. A 17-year-old male is presenting in ICU with right subdural hematoma. And into the day 4 of illness, he is actually intubated and ventilated, and CSF drainage is hemorrhagic. Then he developed high-grade temperature in the morning. So you repeated the cell count and culture, and this is basically your values. So what is your assessment of the CSF?
High WBC count and some gram-positive foci, maybe infected ventriculitis have happened.
Correct.
GPC is there, so it's nosocomial meningitis like picture.
Yeah. So what? So what organisms are responsible for this?
Gram-positive.
Commonest is gram negative, and now sorry, there is
Gram-positive.
GPC, so we have to cover MRSA also.
Correct.
So Staph aureus, cons.
Okay. Appropriate antibiotic coverage.
This vancomycin with ceftriaxone, and this steroid. No, it's nosocomial, so no rule of steroid. So vancomycin and ceftriaxone.
Patient, you had a red flag from your infection control that something is going wrong in your ICU, and we keep getting such kind of calls. So the CLABSI rate is 10, and you did the calculation in this way: number of CLABSI is equal to 3, number of central line placed is equal to 300. So CLABSI rate is equal to number of CLABSI divided by number of central line into 1000. Is it correct?
Into 100.
I think it's
So the denominator
No,
here is wrong. It is
number of
central
cent
line days.
days.
Yeah. So no need for concern right now. It is okay. You can review the data later. 54-year-old male is transferred from ED with progressive neck swelling and not able to swallow. He had a wisdom tooth taken out 3 days ago. And now everything is swollen, voice is hoarse, drooling of saliva is there. He's claustrophobic, tachycardic, hypotensive, tachypneic, and all those. What will you do to investigate this patient further?
Imaging
CT CT.
answers are written.
Is it Ludwig's angina or something? No, it's
Yeah, so you have to do CT only. It could be anything. It could be any, abscess or mass is actually formed after the tooth extraction has taken place. It could be Ludwig's angina also. What is your next plan of action?
ENT reference and keep difficult airway cart ready for
Correct.
airway protection.
Correct. So video laryngoscopy can be done prior to extubation to actually see extubation plan for this patient is video laryngoscopy should be done prior to extubation to see how much of airway swelling is there before extubating the patient. A 125 kg individual is presenting with fever and shortness of breath. He is drowsy and disoriented. His his urea is 50, creatinine is 2.8. And based on this information, how do you classify the severity of pneumonia?
Corp 65. So urea is so age is more than 65.
So curve 65 criteria is what you need. And what are the factors which determine if the patient needs ICU or not?
So
So
score if it's more
more
than
than
2, then
Okay,
needs ICU admission.
good.
more than 3.
Yeah. 54-year-old male is presenting with multiple myeloma with 2 ED. His vitals, hypotensive, tachycardic, febrile. He is day 8 post chemotherapy. And these are his counts. WBC count is 0.9, neutrophil is 0.38. Preliminary diagnosis?
Neutropenic sepsis.
Pancytopenia because of chemotherapy. Neutropenic cell.
Antibiotic of choice?
It should be
Fluoroquinolones can be
gram negative cover. So anti-pseudomonal any gram negative cover along with gram positive.
antifungal.
You have to give MRSA cover also. Sure.
Antifungal also, I think.
Sorry?
It's
Antifungal.
carbapenems or BLBLI covering Pseudomonas and MRSA cover.
Yeah, so one carbapenem and one MRSA coverage should be okay. Consider an antifungal agent you can add. What is the consideration for an antifungal agent you need to add?
Patient not improving with the empirical antibiotics.
Empirical, then we need to.
You don't have cultures right now.
Yes.
Yeah. So patient is not improving by day 3, you can consider to add antifungal day 3, day 4, and worsening fever or something like that. Okay. A 45-year-old gentleman is.
I have a
Sorry.
question. Patient
Yes,
use of antibiotic will depend on the condition of the patient. Is it stable or not stable?
Your
For
voice is not
neutropenia,
clear. Sorry.
patient with neutropenia, choice of antibiotic will depend also on his clinical condition. Is it stable or in shock or not? Or not
Yes,
depend?
definitely it depends on the clinical condition. So as you can see, the patient is hypotensive, tachycardic, tachypneic, and febrile with a fever of 103. That is why we are escalating the antibiotics. It definitely depends on the clinical condition of the patient.
Okay, thank you.
Yeah.
Candida score is needed here
What
in
is needed?
neutropenic patients. Candida score.
Candida score you can do, but usually in the beginning we need not do. If the patient is actually not improving, that is the reason we need to think if we need to add empirically antifungal treatment. 45-year-old gentleman is presenting alcoholic CLD with cirrhosis. He's a frequent flyer to the hospital because of hepatic decompensation. This time he is in ER with immediate ICU admission with vasopressor support. His hemoglobin is actually 11.5, close to the baseline. His abdomen is actually grossly tense and tender on palpation. It's actually reproducible percussion tenderness, and his ascitic tap showed this. So, what is your provisional diagnosis?
Spontaneous bacterial peritonitis.
So spontaneous bacterial peritonitis should have actually finish the
Bacteria
question.
not.
So it's not improving on ceftriaxone. So it is probably not the same
Secondary peritonitis perforated viscous.
bacterial peritonitis, probably secondary to some perforation or something. Why you suspect such a diagnosis and not spontaneous bacterial peritonitis?
As a cause for
High WC count
Yeah.
and no,
the patient has procedure.
there is procedure before.
Actually, no bacteria seen they have mentioned, so I thought maybe it's.
It's actually, yeah, but then in culture, if you see, there is a polymicrobial growth.
So ma'am, the definition of spontaneous bacterial peritonitis is more than 250 polymorphinuclear cells in
That is there.
and along with the single positive culture should be there. If it is
Yeah.
single positive, then it is SPP. If it is negative, that no culture is negative, then it is known as CNNA, that is culture negative neutrocytic ascites. And if
This
it's
is not that.
it is known as secondary bacterial peritonitis.
Secondary
Yeah,
bacterial peritonitis, correct. And any investigation, if you want to do at this point of time to see what is going on, you can say CECT abdomen. Okay. To find out what is going on. If there is any perforation, if there is any secondary cause of peritonitis. Just 1
to
second.
differentiate this primary secondary SAG, whether
SAG will differentiate between spontaneous bacterial peritonitis and secondary peritonitis.
because if it's a liver related, then only I guess. Otherwise, not. If it's a cirrhosis and then SBP, then
SAG is more than 1.1.
yeah.
And in secondary peritonitis, I think also it can come more than 1.1.
So this is
Because in exudative, it is less than 1.1 actually.
so exudative is well less than 1.1. High SAG and low SAG you're talking, no? So low SAG is less than 1.1. You're correct.
Or
This is low
how
SAG.
to differentiate between primary and secondary?
The
Uh,
primary
this-
bacterial
see-
peritonitis is no term. It is same as spontaneous bacterial peritonitis.
So
Yeah,
you have to
not-
see there is
not- yes.
polymicrobial growth. Polymicrobial growth means it cannot be spontaneous bacterial peritonitis. That's all.
Mostly it is monomicrobial, but is it a diagnostic criteria? I mean, it's E. coli is predominant in spontaneous bacterial peritonitis.
Yeah,
But
it is a
that is
diagnostic
only
criteria for SBP, spontaneous.
okay.
The culture should grow only one bacteria, not more than that. It is a diagnostic
So
criteria.
that
for
is the only differentiating feature.
Yeah, yes,
Yes,
yes.
SAG
Because
is
both
not
will have
is,
both will have more than 250 polymorphonuclear cells. But the
Correct.
culture will show single bacteria in spontaneous and more than one bacteria in secondary bacterial peritonitis, which can be secondary to gut perforation or any
Anything.
procedure secondary done.
For that, you need to do a CT scan to evaluate what is going on. That's all.
and
Is it-
and white cells, if more than 1,000, I think it is against SPB.
No,
If
no, no.
two-
There is no criteria like that. You don't confuse yourself. In spontaneous bacterial peritonitis, the count is more than 250 and a single organism growth. That's all you need to know.
Okay.
Anything else is secondary bacterial peritonitis. The polymicrobial growth is there. If the patient is actually not improving on, single antibiotic, and so you have to rule out for secondary bacterial peritonitis. Yeah. Okay. Next question is a patient is you're encountering with an effluent fluid of bluish green in color. He got admitted with gram-negative bacteremia with septic shock and cholangitis on very high NORAD support. Now he's on CRRT. His vasopressor and NORAD requirement have reduced after starting the current regimen. And based on the above finding, this is what the urine output looks like. So what therapy did the patient receive?
Methylene blue.
Very good. What is the indication of methylene blue?
Refractory shock, not responding to empirical antibiotics, and even
Do you have any evidence
Also.
for methylene blue use?
cyanide.
No, it's methemoglobinemia.
No evidence for the use of methylene blue. Any trial that has been done which has shown benefit with methylene blue?
No proven benefits, ma'am.
Okay. So, any contraindication of using methylene blue?
G6PD. Yeah.
G6PD deficiency or patients on SSRIs or SNRIs can precipitate serotonin syndrome.
Yeah.
Okay.
Yeah. And how does it work? It inhibits guanylate cyclase, which stimulates the nitric oxide and other mediators, decreasing the cyclic GMP and vascular relaxation.
The trial name for methylene
There
blue.
has been a trial, I don't remember the name of the
Okay.
trial, but there has been a trial not shown much benefit in terms of mortality, but there has been reduction in NORAD requirement with using methylene blue. And you can remember the dose also, how to give it, loading dose and then
1 gram per kg.
1 to 1.5 gram.
then you have to start a maintenance dose also.
Yeah.
Yeah. A 60-year-old man is presenting in ICU, day 10 of ICU, diabetic perforated gastric ulcer, requiring laparotomy, repair, and washout. He's on empirical piptas for 4-quadrant peritonitis. He's on TPN through right IJ line. He developed high-grade fever temperature. What is the differential diagnosis?
It can be it can be secondary candidial infection.
Yeah, so it can be secondary infection either in the abdomen or what else can be possible in this patient? Right IJV could be.
Infect, yeah. CRBs.
Yeah, so it could be line-related sepsis also. So two possibilities are there. Will you change antibiotic at this point?
I will add antifungal to this patient
Yeah.
because he is going to have a high candida score, right?
Yes.
And
Good,
high
good.
TP and intra-abdominal sepsis and
Good, good. You have to escalate the antibiotics to meropenem, vancomycin, and also you have to add antifungal, okay, because this patient might have a high incidence of this thing, antifungal infection also, considering that
Candida
the
colonization
score is
would be-
also going to be very high. What are the risk factors in this patient? Now that you already answered, what are the risk factors? These are the risk factors. Surgery, TPN, fungal colonization, infection, sepsis. So there are a lot of risk factors in patients. You need to add antifungal coverage in such patients. Male patient is actually presenting with IV drug abuse history and admitted with infective endocarditis of aortic valve. His culture is negative since admission. What are the indications of urgent valve replacement in such patients?
Valve size of vegetation more than 1 centimeter.
Correct. More than 10
by-
millimeter of vegetation.
Or GNB, MDR, GNB infection or fungal endocarditis,
Correct.
worsening like complications like heart failure or cardiogenic shock.
Very good. So worsening heart failure, infective endocarditis left-sided with highly resistant organism, heart block or any other complication
Severe
because of that. What are the organisms we expect in culture negative endocarditis?
HASEC group.
Very good. HASEC group, please
HASEC.
remember what is that?
Yeah.
Haemophilus, actinobacillus, cardiobacterium, Echinella, Klebsiella. They usually grow after 5 days of incubation.
Yes.
Yeah. What is the initial recommended regimen of antibiotic in case of infective endocarditis where the culture reports are not back?
If culture reports are not available,
Not available.
we have to check the penicillin MIC. If it is sensitive, we can start with that. Otherwise, ceftriaxone or vancomycin plus
Culture
vancomycin.
reports are not available. MICs you will check after culture reports.
Yeah, sorry. Then we need to give beta-lactam plus glycopeptide vancomycin.
Correct. So you have to start, you can start with flucloxacillin and benzyl penicillin, and then you have to escalate accordingly. If MRSA is suspected, vancomycin, flucloxacillin.
And then, madam, if MRSA is suspected, why dual coverage with vanc and flucloxacillin? Flucloxacillin will already cover your MRSA. If it is MRSA,
Flucloxacillin doesn't cover MRSA.
sorry. If it is methylene success. So if it is MRSA, then why we are giving flucloxacillin?
So flucloxacillin is supposed to be given for MSSA coverage if you are suspecting Staph aureus. So, but if you have to actually, if you're suspecting MRSA, then you actually give vancomycin. You can stop flucloxacillin. You need not give both. You're right.
Yeah.
Yeah. So you start with flucloxacillin. If you're suspecting MRSA, then switch to vancomycin. That's all. Okay. Is it clear? This is the end of your CBS also. And I think you'll be shared with all the questions and all that. I'm not sure what the academy does in that way, but any other doubts you can actually message on the group also, or you can reach out to us. Yeah. Thank you guys. Thank you for joining.